Okay, we previously spoke about a relatively new area called emerging adulthood, which covered that time period in between adolescence and some of the things that most individuals would consider a demarcation for the beginning of adulthood, such as a full-time job, being completely independent from one's parents, childbearing and marriage and things of that nature. So now we're going to start talking about adulthood, and we're going to be covering a pretty broad range of ages here. Really, we're talking about the ages of about 25 to 65, because after that, we start referring to this as late adulthood. So that's going to be the focus of this lecture is going to be on adulthood and covering specifically the ranges from about 25 to about 65, so about 4 decades. So keep in mind that this is going to be over a very long period of time, about 40 years. The aging process can really be characterized by senescence, which is a gradual physical decline that's related to aging and during which the body becomes less strong and efficient. Let me just point out something here that we're saying that it's related to aging. We're not saying that it's necessarily caused by aging, and really the reason that we make that distinction is because aging per se doesn't cause anything. Aging just refers to the passage of time. It's really other factors such as wear and tear that comes along with this with time, and things like exposure to toxins. That's really what we're talking about when we say the physical decline that occurs. It's being caused by those things, not age per se. Okay, so just something to keep in mind. In terms of the physical appearance, collagen decreases by approximately 1% each year, and the collagen is that substance that is the main connective tissue of the body, and so it gives our skin the ability to be somewhat elastic, and if we pull on our skin, it goes back to place. Our skin becomes a little bit saggier and more wrinkled as we get older because of primarily a loss of collagen, among some other things. The hair begins to turn gray and it gets thinner, leading to some baldness in men more so than in women, although women's hair does thin out as well. The middle age spread, which refers to a greater accumulation of body fat around the waist area, so it tends to accumulate there rather than being more evenly distributed throughout the body during younger adulthood. The muscles weaken. There's much muscle atrophy, which means a wasting away of muscles. There's a height decrease that begins by late middle age, which has to do with compression of the spine and loss of that protective tissue in between the vertebral bones, and many changes occur more slowly in people who exercise and are just generally more healthy. Exercise and diet are two of the main factors that are going to really determine how quickly these things take place. So it's not really age that's the most important factor. It's really what we do over the course of those years. In terms of vision, we see that peripheral vision tends to narrow faster than frontal vision. So it's a little bit harder to see things that we're not looking directly at. That's our peripheral vision. Color vision shifts from vivid to faded more quickly than does black to white. Than does black and white. Nearsightedness tends to increase gradually beginning in one's 20s. So probably a lot of people that or maybe yourself, wears glasses, and if that's the case and you're a young adult, it's probably for nearsightedness, which means that you probably have difficulty seeing a chalkboard if you sit in the back of the class. Farsightedness tends to become more prevalent during middle age, and this is a result of the lens of the eye becoming less elastic. and the cornea flattens. So what that essentially means is that we don't have the ability to curve our lens as much that would normally allow us to see things that are up close. So we have difficulty seeing things up close the older we get. And whereas younger adults are usually either nearsighted or farsighted, most older adults develop both of these conditions. So here we can see, the course over the the change in vision over the course of the lifespan. So at around age 20, most people between 20 and 40 have better than 20/20 vision. And that after about age 40, you see there's a change in visual acuity, such that by age 60, we're still at roughly 20/20 vision, but by age 80, we're seeing things that are 20 feet away from us about as clearly as if it were 50 feet away from us. And we also see changes in accommodation, which refers to our ability to put things in focus by moving our lens, which we said becomes less plastic as we get older. We become less able to adapt to changes in how close or how far something is away from us. And you can see here that there's a line here marking what's called presbyopia, and that is one of the age-related vision changes that we see. So after you lose a certain amount of elasticity in the lens, that marks what we call presbyopia. Presbycusis refers to a loss of hearing that's also associated with senescence, and usually does not become apparent until after age 60. So this is a loss of hearing. It tends to happen more severely in males, and in particular, we tend to lose our ability to hear high frequencies before we lose the ability to hear low frequencies. And this picture here is illustrating the fact that once again, age is not the most important factor. It's really your exposure to loud environments that's going to determine when this is most likely to occur. In terms of sexual responsiveness, sexual arousal becomes, it occurs more slowly with age, and orgasm also takes longer. There's often distress experienced by individuals because of this. They experience distress at the slower responsiveness, and it's more associated with anxiety in interpersonal relationships and expectations than with aging itself. But what studies do find is that adults of all ages enjoy very high levels of emotional satisfaction and physical pleasure from sex within their relationships, and men and women were most likely to be extremely satisfied with sex if they were in a committed monogamous relationship. So, in other words, most people are still quite content even in older adulthood. As you can see, in fact, people become even more content. These are the percentage of adults who reported that they were comfortable monogamous, meaning that they are satisfied with being with one and only one partner, and a slight difference between males and females, but for the most part, for both sexes, that percent increases from 20 to 60. Fertility issues become more and more prevalent the older we get, both for males and females, although perhaps to a greater extent in females. Infertility is most common in nations where medical care is scarce and sexually transmitted infections are common. In the United States, about 15% of couples are infertile, partly because many postpone childbearing, and the older you get, the more difficult it is to conceive. When couples in their 40s try to conceive, about half are infertile, and the other half risk various complications. In other words, the risk of complications during birth, and also with development in general of a child born to parents who are older than 40, and in particular mothers who are older than 40, there's a higher risk of complications associated with that. There are multiple factors that are responsible for male infertility, but advanced age, fever, radiation, prescription drugs, stress, environmental toxins, drug abuse, all these things can have an impact, and specifically an adverse impact in the sense that they reduce both sperm number, shape, and sperm motility. For females, their fertility is affected by anything that impairs physical functioning. So advanced age is in there, disease, smoking, extreme dieting, obesity. But another factor that can result in infertility in women is pelvic inflammatory disease, which can block a woman's fallopian tubes, which prevents sperm from reaching an ovum. There are some treatments that can result in successful fertilization, and these are called assisted reproductive technologies. Advances in medicine have solved about half of all fertility problems, and it overcomes obstacles such as low sperm count and blocked fallopian tubes. So there are ways to get around that, and one technique called in vitro fertilization is a technique in which an ova or egg cell is surgically removed from a woman and fertilized with a sperm cell in a laboratory. After the original fertilized cells, called the zygotes now, as you recall, have divided several times, they're inserted into the woman's uterus. So one of the reasons that it seems like there's a much more, a greater impact in terms of age on women's fertility is because, as with the development of puberty, where there's an abrupt onset, there's also an abrupt offset for women, and that's called menopause. So menopause is the time in middle age, around age 50, when a woman's menstrual period ceases completely, and the production of estrogen, progesterone, and testosterone drop considerably. And menopause is officially determined as 1 year after a woman's last menstrual period. So after menopause, there's an abrupt halt in women's reproductive ability. Not the case for males, although there is a change in males' fertility, as we discussed, which we'll talk about in a minute. One actually turns out to be a relatively controversial treatment has been hormone replacement therapy. This is a treatment that's used to compensate for hormone reduction at menopause or following surgical removal of the ovaries. Such treatment, which usually involves a combination of both estrogen and progesterone, minimizes menopausal symptoms and has been shown to diminish the risk of osteoporosis in later adulthood. So it sounded like it was a great thing, and it was recommended for a long time. Although some clinical trials revealed that hormone replacement therapy may involve health risks, and in particular, it seemed as if it may have increased the risk of certain types of cancer. And so for a while it was not recommended anymore. And at this point, there's sort of a trade-off between the benefits that come from it in terms of minimizing those menopausal symptoms and osteoporosis, and the possibility that you may be increasing your risk of cancer. It's certainly not definitive by any means in terms of how great the risk is, but it seems as if it's high enough where it's not recommended for everyone. So andropause, this is a term that was coined to signify a drop in testosterone levels in older men, which normally results in things like a reduction in sexual desire, erections, and muscle mass. There's also a type of hormone replacement therapy for men. You probably have seen commercials for testosterone supplementation in the form of gels or patches or something like that. The effectiveness for these for hormone replacement therapy in men is a little bit questionable, although there's certainly evidence that increases in testosterone through medications do have a number of both psychological and physical benefits for many men. In terms of drug use, tobacco sees a noticeable decline in the United States, particularly over the past 50 years, although worldwide trends are far less encouraging. Smoking rates in developing nations are actually rising, smoking-related cancers throughout the world are increasing, and we're likely to see that. As these developing nations become more developed, there probably will be a decrease in these things. But there are great variations among nations, cohorts, and the sexes, which indicate that smoking is largely affected by things like social norms, laws, and advertising. And we can see in this graph some cohort effects. A cohort effect, as you may recall, is a change or a difference that can be observed between people of different ages that's not necessarily due to a change in age, but rather it seems to be an effect that's due to the time period in which people were born. So what I mean by that is that you can see that many more emerging adults were smoking in 1970 than were in 2007. There was, a relatively significant drop between 1970, the proportion of people smoking then, and the number of people smoking in 2007. Now, these are both emerging adulthood here, emerging adults that we're looking at. So it can't be an effect that's due to age, but yet there's still a decrease. So it's probably a fact. It's probably a reflection of the fact that these individuals in 2007, the environment that most likely discouraged smoking was not the same environment that was present in 1970. There was much more controversy about how bad smoking actually was for you. But we do also see some declines in the proportion of people smoking as a function of age as well, because if you look at these people here in 1970. Okay, these emerging adults here in 1970 are the adults who are now over age 65, or perhaps close to 65 over here. And so if you compare these bars here with these bars here, you see that there is a decrease. So fewer percentages of adults are smoking. Now, that could be for one of two reasons: either people have decided to quit smoking, or people have died who were smokers. In terms of alcohol use, drinking in moderation has been shown to have some beneficial effects, and in particular, it seems to be associated with an increase in life expectancy. Although, keep in mind that we are talking about drinking in moderation, which typically means no more than about 2 drinks a day. How does it do this? Well, alcohol seems to reduce coronary heart disease and also the likelihood of having a stroke. It seems to also increase good cholesterol, that's HDL cholesterol, and reduces LDL, or low density lipid cholesterol, which is the bad cholesterol, and it also seems to lower blood pressure. On the other hand, heavy drinking increases the risk of violent death and is implicated in a number of diseases. So heavy drinking has very detrimental effects. And there are also stark international variations in alcohol abuse. Binge drinking certainly is a signal of a problem and is pretty prevalent. About 20% of U.S. adults had 5 or more drinks on a single occasion in the past year. There's a disproportionate burden of harm, or there may be a disproportionate burden of harm in poorer countries because prevention and treatment strategies have not been fully established. It's sort of similar to the trend that we saw with tobacco use. So what we're getting at here is that a lot of poor health habits, drinking and smoking and drug use, have a great impact on senescence, on the way that we change physically over the age span. Overeating is another one. Many adults choose high-calorie, low-nutrient foods. Obesity has officially become an epidemic. Okay, it's a major problem, and it's a major problem specifically for the U.S. Lots of countries are facing an obesity epidemic, but the U.S. has one of the highest rates of obesity. Only 27% of the U.S. adults eat 3 daily servings of vegetables. They eat too many high-calorie foods combined with too little activity, and this is what largely accounts for the rise in obesity. So excess weight increases the risk of every chronic disease, for example, diabetes, but of course, the older we get, the higher the risk of things like stroke and heart disease and all those sorts of things. So it's a real serious problem. The United States has the highest rates of obesity and diabetes. As I mentioned a minute ago, 66% of adults are overweight, and of those, 33% are obese and 5% are morbidly obese. So this is typically calculated based on the body mass index, which is the ratio of height to weight that we discussed earlier. Metabolism decreases by about a third between ages 20 and 60. So that may seem like that may be partially responsible for the increase in obesity. The fact that our metabolism is lowering, and also there are certainly some genes that have been identified, and in fact there are two alleles that correlate with both diabetes and weight. So it suggests that there is to some extent a biological influence here. Yet the increase in obesity rates certainly cannot be blamed on genes, because genes don't change very drastically from one generation to the next, yet the rate of obesity has changed drastically from one generation to the next. And so that's clear evidence that cultural influences are much more important than our genetics. And in particular, it's not just eating, of course, it's also inactivity. Regular physical activity at every age, at every stage of life, protects against serious illness. Sitting for long hours correlates with almost every unhealthy condition. And even a little bit of movement helps, but of course the more intense exercise, the more ideal it is, up to a certain limit, of course. You don't want to overdo it and cause potential harm to your body, but engaging in things like swimming, jogging, and bicycling is ideal. So in other words, become a triathlete. The connection between exercise and health is causal. Most people who are fit are likely to resist disease and feel healthier as they age. Factors that prevent a decline in exercise. The older we get, the less likely we are to engage in exercise, although certainly those individuals that start off exercising at young ages are much more likely to continue to do so. But some factors that prevent a decline in exercise are friendship. So people who have friends that exercise are more likely to exercise themselves. And also the community has an impact. Adults are more likely to exercise in neighborhoods with things like walking and biking paths, ample fields and parks, and subsidized pools and gyms. So what New York City does for its residents, having all these New York City parks and recreation centers that are available either for free or for a very low cost. That certainly increases the likelihood of people engaging in exercise because those facilities are available. So we've been talking about some things that impact health, but we need to talk a little bit more about how exactly we measure health. And there are a few different ways that we could measure health. One way is through mortality. Mortality is death. Okay, and it's usually refers to the number of deaths each year per 1,000 members of a given population. So, the more number of deaths per 100 members of a given population, the higher the mortality rate. Okay, rate is a number of occurrences per unit of something else. Morbidity refers to disease, and it refers specifically to the rate of diseases of all kinds, physical and emotional, both acute or sudden, and chronic or ongoing, as well as fatal in a given population. Okay, another factor that we can look at is the rate of disability, and disability refers to long-term difficulty in performing normal activities of daily life because of some physical, emotional, or mental condition. Any one of those things can result in a person being disabled. And also vitality, a measure of health that refers to how healthy how healthy, excuse me, and energetic, physically, emotionally, and socially an individual actually feels. So, this one gives us vitality gives us a measure of how a person feels. Disability gives us an indication of how well someone is actually functioning. Morbidity refers to just whether they have a disease or not, because whether you have a disease or not doesn't necessarily dictate whether you have a disability, or it doesn't indicate your vitality either. So all these factors are important to consider when we talk about the health of an individual. There are also variations in health, and specifically there are gender differences. Mortality is lower in women, which means that there are more women in relation to men the older people get. Women live on average 5 years longer than men, although there are significant national variations. It's about 5 years in the United States, but in some countries it's even higher, and in some countries it's even lower. Older women outnumber old men, primarily because more younger men and boys die. So the sex ratio favors boys at birth. There are actually more boys born than girls. It's about equal. There's about the same number of males and females at age 20, and then it tends to tilt toward women from then on, to the point where by age 80 or so, there's something like 3 women for every 2 men, approximately. Gender differences, these things might be biological. There's some suggestion that having the second X chromosome that females have, remember that females have 2 X chromosomes in their 23rd pair. Males only have 1 X chromosome because they have their Y chromosome as well. And there's some suggestion that second X chromosome may have some protective mechanism associated with it, or it could have something to do with the extra estrogen that females have, or alternatively it might be purely cultural, or at least partially cultural. That is, women, they tend to have more friends and take better care of themselves. They're more likely to go see the doctor, more likely to get treatment for ailments and things like that. So those things are also going to play a factor. Although women may suffer more on other measures of health. For instance, both sexes notice superficial signs of aging in women more than men. In other words, more women are likely to go for botulinum toxin injections to try to reduce wrinkles. They're more likely to dye their hair, things like that. Women have higher rates of depression than men. And that's basically from puberty on that occurs. Women have higher rates of morbidity every year, except for chronic diseases such as heart disease. But for the other chronic diseases, women tend to have higher morbidity rates. And part of this may have to do with the fact that women are living longer as well. But also more women are disabled. Socioeconomic status is another important factor. So well-educated, financially secure adults, they tend to live longer. Some of the suspected reasons for this include things like education, which may teach healthy habits. Education may lead to higher income. In fact, it does typically lead to higher income, and this can allow better housing and also better medical care, or even just insurance in general for medical insurance. And education may be a marker for intelligence, which is also a protective factor. In fact, it's very difficult to differentiate the benefits of intelligence from the benefits of socioeconomic status because they are very similar to one another. Here's a graph showing us the impact of culture on health. What's interesting is that we can see that regardless of culture here, or race or ethnicity, immigrants so individuals who come to the United States are less likely to have plaque buildup. Plaque buildup is a risk factor for cardiovascular disease, and when we compare those who are foreign-born with those who are born in the U.S., so they're the same ethnicity. It's just a function of whether they were born here or not. And we see that if you were born here, regardless of whether you're white, Chinese, black, or Hispanic, if you were born in the United States, you have a higher prevalence of plaque. And again, that's a proxy for measuring cardiovascular disease susceptibility. In terms of cognition in adulthood, we see that older adults tend to have greater difficulties with multitasking. Reactions take longer, and complex memory tasks become more difficult because of age-related brain changes. Multitasking becomes more difficult with every passing decade. But the most significant differences can be seen, of course, when you compare a 25-year-old to a 65-year-old, but it's a slowly progressive change. As an example, driving while talking on a cell phone becomes more difficult for older adults because it involves the dividing up of attention, and they have less attentional resources to divide up as we get older. And also, we also become more susceptible to distractions. So, for instance, noisy conversations, when there's noise in the background, it can be more difficult to attend to an individual conversation that we want to, and also emotional distress can become a significant distraction. The regular need for sleep is increasingly essential for proper brain functioning. Skipping a night's sleep slows down cognitive functions, for example, memory. Most college students are very familiar with the effects of not getting enough sleep, and disrupted sleep is characteristic of aging and can cause serious problems. One of the big reasons that it's characteristic of aging is because of nighttime awakenings. We tend to spend a little bit less time in those deeper stages of sleep that we're less likely to wake up from, and they also wake up because they have to use the bathroom more times than younger adults do in the middle of the night. So all those things essentially lead to greater disruption of sleep and less overall sleep as a result. Now, it's important to distinguish between a serious change in cognition that's referred to as dementia. This is very uncommon in individuals under age 65. Less than 1% of individuals under age 65 have dementia, which is essentially a neurocognitive disorder, and there are different forms of dementia that we'll be talking about a little bit later on. But for right now, let's keep in mind that we're not talking about dementia, we're talking about normal age-related changes in cognition. And once again, lifestyle factors are very important to consider here. They're probably more important to consider than age per se. And some of those lifestyle factors include drug abuse, so alcohol, cigarettes, and psychoactive drugs can all have a damaging effect on our brains. And also excessive stress can have an effect on our brains, in part because it can lead to depression, and also because it can also have an effect on our immune system. And there are stress hormones that are produced, and with excessive stress, that results in excessive production of stress hormones. And those stress hormones, while they're adaptive in the short term, can have detrimental effects in the long term. Also, poor circulation, everything that protects the circulatory system, for example, exercise, a healthy diet, and low blood pressure, also protects the brain. And finally, viruses. Some viruses and infections are able to cross the blood-brain barrier and can harm the brain. So, for example, people who develop HIV can develop what's referred to as HIV-related dementia. There are other diseases such as mad cow disease that can also result in dementia. But probably one of the most important things to keep in mind here is that past education, current intellectual activity, exercise, and overall health all promote brain function. So although these are the things that that can disrupt brain functioning, keep in mind that we have a great deal of control over this. When we look at research on age and intelligence, we have to think about what we mean when we talk about intelligence. There are lots of different ways, and there are many theorists that have proposed different theoretical explanations of what intelligence is. One suggestion is that there's something called general intelligence, often symbolized by the lowercase letter g here. This is a construct based on the idea that intelligence is one basic trait that involves all cognitive abilities, which people possess in varying amounts. It cannot be measured directly, but can be inferred from various assessment of abilities. So, for example, vocabulary, memory, and reasoning are the typical types of things that would be measured in order to determine someone's overall general intelligence. Many scientists are trying to find the common factor, for example, genes, early brain development, or some specific aspect of health that underlies intelligence or IQ. And just to differentiate between IQ and intelligence, IQ is a numerical value that it comes from a test of intelligence. Now, intelligence itself is very different than the score that someone receives on a test that's meant to try to assess intelligence. Okay, one helpful way to think about this is to compare the idea of general intelligence to something like general health or general fitness, right? So, think about somebody that you would consider to be very fit, right? Maybe you know somebody who is a marathon runner and you consider that person to be very fit. Maybe you know somebody else who's a weightlifter, and maybe they're very fit. There are very different types of fitness. One is cardiovascular fitness, and one is more largely based on strength fitness. And is there something that characterizes both of those individuals? That's what we're looking for when we're looking for G in terms of general intelligence. What is the common factor between a weightlifter and a marathon runner that allows us to consider them both to be fit? Okay, so just keep that in mind as we're talking about this. Now, some of the early research on the relationship between age and intelligence came primarily from cross-sectional research. And as you recall, cross-sectional research involves comparing people of different ages in order to try to assess differences in age groups. And some of the early testing came from the U.S. Army. They tested the aptitude of all literate draftees during World War I. And what they found was that intellectual ability peaked at about age 18, stayed at that level until the mid-20s, and then began to decline. So it seemed like, another study of almost 1,200 individuals between 10 and 60 from New England villages similarly found that IQ scores peaked between ages 18 and 21 and then gradually fell, with the average 55-year-old scoring the same as the average 14-year-old. So again, the early cross-sectional research, and actually some cross-sectional research after this as well, but these are some of the earliest studies on this, on the relationship between age and intelligence, found that it tends to peak very early and then there's a gradual decline. When we look at longitudinal research, keep in mind that this is when we look at the same group of individuals, track them over time, so that we look at a 30-year-old, but then we look at that same 30-year-old 10 years later at 40, and then 10 years later again at 50, 10 years later again at 60. And it's very interesting that these two different types of research found very discrepant findings. Longitudinal data found that many intellectual gains occur through adulthood, but that younger cohorts often did better than older cohorts. So again, we see that there were cohort effects, just like we talked about cohort effects with smoking. This is probably due to changes in the environment. For instance, more education, improved nutrition, smaller family size, fewer infections, and not changes in innate intelligence per se. In other words, it's not as if people's innate abilities or the abilities that they're born with had changed, but rather the environments had changed. And probably the biggest thing that I can think of that's changed is, not to say that these things are not all important here as well, they certainly are, but the invention of the internet. I mean, we could look up something on our phones right now and get the answer to a very complex question if we wanted to, as opposed to prior to the internet, that would probably require a great deal of effort on our parts. So with just the click of a few buttons now, we can answer those types of things, and those are the types of things that are going to make it look as if our intelligence has actually increased. So longitudinal research is better than cross-sectional research in the sense that we're tracking people, the same people, over time, but it also has its problems. For example, practice effects, meaning that the more we take tests, the better we do on them. So that can make it look like we're getting better, even if we're really not. And high attrition rates, which means that people drop out of longitudinal studies, and the people who tend to drop out of studies, they tend to be often lower functioning than the people who remain in studies. So once again, that can make it look like people are improving when in fact it's just that the people that were not improving were more likely to drop out. So what's the solution to this? Well, cross-sequential research, as you may recall, combines both cross-sectional and longitudinal designs, and by far probably the most well-known cross-sequential research study is called the Seattle Longitudinal Study. This is a cross-sequential study of adult intelligence, and it was begun by a researcher whose name was K. Warner Shea. He began this study in 1956, and the most recent testing was conducted in 2005, and there will probably be a follow-up in the near future. It included 500 adults between age 20 and 50 who were tested on 5 primary mental abilities. And what he did, so he tracked them over time, that's the longitudinal component, but he also compared the individuals of different ages, that's the cross-sectional component, and he continued to add new cohorts every 7 years. So here are these 5 primary mental abilities that we just mentioned on the previous slide. There's verbal meaning, which is basically comprehension or vocabulary. How many words do you know? The definition of spatial orientation. So can you navigate a map well, for instance? That's a spatial type of task. Inductive reasoning. Can you use examples of things to come up with general principles that explain those things. Number ability, that's just your basic how good you are with numbers. If I give you some math problems to do in your head, could you do them right now? And word fluency, which is how many, basically it's typically tested with how many words can you name of a particular letter or of a particular category in 1 minute. So these are just rapid associations. And the findings from the study found that people improve in most mental abilities during adulthood, and decline occurs later in life. So each particular ability has a distinct pattern for each gender. So here are the results of his study. Here we're looking at the mean T-scores of women. Here we're looking at the mean T-scores of men. And a T-score is a standardized score where which just means that it doesn't represent the number of things that you get correct per se, but it represents what the average is. So 50 is average. Anything above 50 is above average. Anything below 50 is below average. And so you see that up until about 60, things remain pretty stable. Okay, there's maybe some decline, but there's also some increase. In particular, verbal meaning is increasing, whereas word fluency is starting to decrease by the age of 60. So that's what we mean when we say that there's a different trajectory for each of the different primary mental abilities. So this is really interesting data in the sense that it contrasts with what those early studies based on only the cross-sectional research seem to be showing. Another way to conceptualize intelligence is to think of it as being fluid and crystallized, and this conceptualization is attributed to Cattell. Fluid intelligence refers to those types of basic intelligence that make learning of all sorts quick and thorough. Abilities such as working memory, abstract thought, speed of thinking are usually considered aspects of fluid intelligence. Okay? In other words, fluid intelligence is basically intelligence that is not learned. In other words, how quickly can you learn information that you've never been exposed to before? How quickly you can learn that information is probably a reflection of fluid intelligence. Crystallized intelligence is, in contrast, based on the types of things that we have already learned. So, if you think that somebody who knows a lot of information is smart, then you think that they're high in crystallized intelligence. Okay, these are the types of abilities that reflect accumulated learning. So, vocabulary and general information are examples of crystallized intelligence. Now, another conceptualization of intelligence comes from Robert Sternberg. He said that there were 3 different types of intelligence, or clusters of intelligence. Analytic intelligence, which is valuable primarily in high school and college, as students are expected to remember and analyze various ideas. Analytic intelligence is the typical type of intelligence that's tested by IQ tests. Creative intelligence, on the other hand, this allows people to find a better match to their skills, values, or desires, and it's kind of what it sounds like. It's the ability to be creative in a way, the ability to see things from a different perspective, see things differently than maybe the traditional way that things are viewed, the idea to generate new ideas. Those are all examples of creative intelligence. And then practical intelligence is useful as people age and need to manage their daily lives. In other words, practical intelligence is your ability to sort of adapt to different demands that you might be faced with throughout life. It's your ability to apply things in order to solve problems. And then finally, another type of conceptualization of intelligence comes from Howard Gardner. He said that there were 9 clusters of intelligence which have a significant amount of cultural variation. He talked about linguistic, logical, mathematical, musical, spatial, bodily, kinesthetic, naturalistic, social understanding, also called interpersonal intelligence, self-understanding, also called intrapersonal intelligence, and existential intelligence. And each culture stresses a different set of Gardner's 9 types of intelligence. What he said was that everyone has all 9 types of intelligences to some extent, but each person develops only some of them. Or it might be more accurate to say each person develops some of them to a different extent, we might say. So you might be, an expert at playing a musical instrument, but you may not be very good in math, for instance. Someone else might be an expert linguist, and also very good at math, but not very good at musical abilities. As it applies to older adults, Paul and Margaret Baltes came up with the idea of selective optimization with compensation. And what this refers to is the theory that people try to maintain a balance in their lives by looking for the best way to compensate for physical and cognitive losses, and to become more proficient in activities that they already can do well. In other words, to break this model down, selective means that as we get older, we become more selective. That is, I might choose to do certain things that that are more important to me, and I might choose not to do those things that are less important to me. Optimization refers to, now that I've selected what I want to do, let me make the most of my time, even though it might take me longer to read things that I'm particularly interested in. Let me optimize my time by choosing only those things that I'm going to get the most benefit from. And compensation means that, given that I might have some physical or cognitive decline as I get older, let me find ways that I can still do the things that I like to do, even though I might have difficulties with vision or I might have, my hearing might start to be going. Let me find ways that I can get around that. So, for instance, let me maybe buy some books on tape and listen to those so that I don't have to worry about straining my eyes or something like that. And then finally, let's talk a little bit about expertise, because expertise is typically something that we don't associate with young people. We typically don't say that young people are experts. If you think about, when you go to see a doctor, do you want somebody who's fresh out of medical school, or do you want somebody who has been seeing cases like the one that you potentially may have for 35 years? That person obviously has quite a bit of experience, and most people would say that they would prefer to go not with the person who is fresh out of school, but rather with somebody who's got so much experience. So expertise. We tend to think of older adults as being experts, and whether or not older adults are experts or not, of course, depends on life experiences. But a selective expert is someone who is notably more skilled and knowledgeable than the average person about whichever activities are personally meaningful. So, in other words, if you're a selective expert, your expertise is in a specific area that you probably chose to become an expert in because either you found it enjoyable or it came naturally easy to you or something like that. So there's culture and both contexts that guide expertise, and what we find when we study experts is that they're more skilled, proficient, and knowledgeable at a particular task than the average person, especially a novice, which is a person who's literally new to something, and who has not practiced that skill. So experts do not necessarily have extraordinary intellectual ability, but rather they've honed in on a particular skill that they've had extensive experience with. Expertise is intuitive. What that means is that experts tend to rely on their past experiences and on immediate contexts. Their actions are more intuitive and less stereotypic. Novices, they tend to follow formal procedures and rules. It's harder for them to deviate from maybe the instructions that they're given on how to do something. Experts, again, they rely on their past experience and immediate context. They're not the type to follow things by the book, but rather use their experience to draw upon and make modifications to an existing set of instructions when they find it necessary. And also, expertise is automatic. Experts process information more quickly and analyze it more efficiently than non-experts, and then they act in a well-rehearsed manner that appears to be largely unconscious. Expertise is also strategic. Experts have more and better strategies, especially when problems are unexpected, and they tend to be creative and curious, deliberately experimenting and enjoying the challenge when things do not go according to plan, and that's what characterizes the flexible aspect of expertise.